Hello students, this is Shyamsundar working as Assistant Professor from the Department of Dialysis and Technology at School of Dialysis, Vinayaga Machines Research Foundation, Salem. Now we are going to discuss about the topic is vascular access. Before into the topic, we have to discuss what is vascular access. Vascular access is the surgical site where blood is taken out from the patient's body, pass through the extracorporeal circuit and then back return to the patient's body. In this, how it's done? It is done by the vascular surgeon. What they do means the anastomosis or artery and vein patient's body. So from that they take blood from the patient's body artery line and then pass to the extracorporeal circuit, which is a dialyzer, and then from that the metabolic waste products like creatine, urea and the metabolic waste products are get filtered, and then the fresh purified blood is back to the patient's body. So from here we have enter into types and its complications, last conclusion. So first we enter into types of vascular access. From this, first we are going to see about permanent vascular access. Permanent vascular access, there are three types. First, AV shunt, AV fistula, AV graft. First we are going to see about AV shunt. In AV shunt, in 1960, Dr. Berlin Scribner found a new thing called arterial shunt, a plastic tube which connects artery and vein outside the skin. From this, the common site for AV shunt was between the radial artery at the wrist and the cephalic in the forearm. The vessel tip is connected to a semi-transparent elastic tubing. One vessel tip is inserted into the artery and the other tip is in the vein. From there, the elastic tube is taken out through the skin by leaving some part into the subcutaneous tissue. The end comes out of the body through a skin puncture called exit site. From that, the end of those tubes outside the body are connected to each other using a Teflon connector. This arrangement will permit the blood flow from artery to vein through the shunt continuously. During dialysis, the Teflon connector was removed and then elastic tubings are connected to the arterial and venous blood line. So this is a picture. This is artery and this is vein and this is the AV shunt, which is described by Scribner and Scribner. From there, blood is taken out and then purified blood back to patient's body through venous line. And this is the inside internal segment. This shows how they anastomosis these things into your body. So this is artery and this is vein. So this is called AV shunt and this is the AV shunt, which is called a Teflon vessel tip, venous return port, Teflon plug and arterial elastic tube, elastic tube. So this is a thigh AV shunt where this is a great surface vein and this is anastomosis, and this red is called superficial femoral artery. From this, the continuous flow of blood to the shunt tubing is restored. Since the Teflon metal does not cause inflammation of the lining of the blood vessels, if carefully used, the AV shunts can be used for many years. It is necessary to check for continuous blood flow through the shunt by inspection, and touching there will be slight warmth in the tubing and pulsations may be felt. AV shunt is not used now due to some reasons. Next we are going to see is arterial fistula, which is man-made. In this, the patient's own artery and vein get anastomosis by a vascular surgeon. From there, blood is taken out and passed to the extracorporeal circuit. From there, the metabolic waste products like urea, creatine, excess fluid are get filtered and then get back to the patient's body. Usually, anastomosis is made at the wrist between the radial artery and the cephalic vein. And AVF cannot be used immediately as a fistula maturation process because it takes around 6 weeks to mature. During the maturation process, blood flow through the newly created fistula will gradually increases due to dilation of both artery and vein. Pressure and flow induce remodeling, thickening of the wall or the fistula vein, which is a section when the needle will be inserted. So this is how they connect and what end to which end. In A, we see end artery to end vein anastomosis. In B, we see side artery to end vein anastomosis. In C, we see end artery to side vein anastomosis. And last D, we see side artery to side vein anastomosis. So this is how they do anastomosis in this technique. Next we are going to see is rule of 6. In rule of 6, there are 6 points of main, which is the vein diameter should be 6 mm, 6 weeks of maturation time, 600 ml of blood flow, 6 mm below the skin, 6 cm length, 6 cm distance between two needles. Now we are going to see about complications. Complications we see stenosis, pseudoaneurysm, infiltration hematoma, infections, Still syndrome. Stenosis means it's abnormal narrowing in the blood vessels. Pseudoaneurysm means occurs when a blood vessel wall is injured, blood leakage from the vessel collects in the surrounding tissues. Infiltration hematoma is like due to improper cannulation technique. Infections, signs redness, pus, abscess and warmth. Last, Steele syndrome. It is due to ischemia of distal extremity. So this is a picture show how hematoma occurs. This is swollen hand incidence stenosis, and this is AVF aneurysm, and this is bluish hand indicating Steele syndrome. Next was advantage of AV fistula and its disadvantage. First we are going to see about advantage. In advantage, what they are trying to say means low infectious rate, lower incidence of thrombosis, patency, long lasting usually for many years. Patency means it's like a proper flow of blood without any obstruction. There is the blood flow normal way and proper way without any obstructions. So we call it as patency. Disadvantage means long time for maturation, not possible for all patients. An AV fistula can't be developed, and AV connection is done using a graft tube made up of PTFE. PTFE nothing but a polytetrafluoroethylene. It's a biological synthetic material, sometimes polyurethane. It may be placed in straight, loop, curved configurations. Most common set of AV graft is upper arm from brachial artery to axillary vein, sometimes brachial artery to basilic vein. What are these advantages are short maturation time, easy cannulation, large surface for needle, easy surgical handling. Next is disadvantage. Highly risk of clotting, thrombosis, severe bleeding, short lifetime very low. AV graft connections. So this is how they do AV graft. So this tube is called a PTFE, which is a polytetrafluoroethylene graft, and this is a brachial artery. Blood returned to the patient from mortal kidney. From here blood flow from graft to artificial kidney. So this is ulnar artery, cephalic vein, radial artery. So this is a AV graft connections. Next we are going to see is axillary graft. Axillary graft is a simple connection between axillary artery to axillary vein by a PTFE material. Next we are going to see is necklace graft. It's a type of graft which bridges between right axial vein to left axial artery by PTFE. Thigh graft. This graft is a simple bridge between a femoral artery and a femoral vein. So this is a axillary artery, this is axillary vein, axillary artery, and this is brachial artery, basilic vein, and this is radial artery, and this is ulnar artery. Next is this is necklace graft, which is they connect between like a bridge between, and it looks like a necklace graft. So this is right axial vein, and the red indicates right axial artery. This is left axial vein, and this indicates left axial artery. So from there they do anastomosis. It's like a ringed PTFE graft. It's like a tube. It looks like a necklace graft. And last, this is thigh graft, which they do PTFE material between your thighs. This works like a bridge which connects between artery and a vein. Next is hero graft. Hemodialysis is reliable outflow. This is alternative to central catheters. The graft is anastomosis to brachial artery. The venous outflow is placed percutaneously into the right atrium through the subclavian or jugular vein and supravena cava. A special graft provided for patients who have a failed graft or blockage or clot within their blood vessels that prevents them from receiving a fistula or graft. So this is a hero graft. From there, this is a PTFE material, and this is a hero 1002 archer graft component, and this is a venous line like hero 00101 venous outflow compartment. Next we are going to see is temporary access. Temporary access, what comes means the vascular access for short term dialysis is by using double lumen dialysis catheters, which can be easily placed in a femoral, subclavian, jugular vein. They cannot be used for long term. When patients' kidney disease progressed quickly, then we may not have a time to get a permanent access, means we can starting a hemodialysis treatment. In this case, we need to use venous catheter as a temporary access, not a permanent access. Catheters differ for material, length, lumen size, configuration, inlet or outlet holes, and methods of connections. What all comes in temporary access means femoral, IJV catheters, and permanent, there are tunneled, cuffed subclavian catheters. Temporary catheters are primarily composed of polyurethane. Tunneled and cuffed catheters are primarily composed of silicon and silicon elastomers. So this is a outline picture for catheters, and this is a IJV, which means a intrajugular vein insertion, and this is a PICC, and this is called a subclavian vein. This is femoral vein catheter. So these are all the how we placed temporary access and permanent access. Next we are going to see about immediate complications. Immediate complications means if we put catheter means onset the complication will come. So that's called immediate complication. So the complication, what are the complications comes in immediate means arterial puncture, pneumothorax, hemothorax, arrhythmias, air embolism. Pneumothorax means there is some air present in the pleural cavity. And hemothorax means there is some blood present in the pleural cavity. Arrhythmias means irregular heart rhythm and air embolism. And finally, delayed complications. What all comes in delayed means thrombosis, infection exits internal, vascular stricture, CR by C, nothing but a catheter related bloodstream infections. So what are all these off lives for each catheter means? For femoral it's about 5 to 7 days, subclavian up to 6 months, and IJV up to 15 days. Last we are going to see about venous catheter. For which patients we do venous catheter means those with acute renal failure, those requiring hemodialysis or hemoperfusion for intoxication, those with late stage of chronic disease needing urgent dialysis without available permanent vascular access. Patient who having failed permanent access, we can use venous catheter. Next, what are the care for venous catheter? The lumen and catheter never remain open to air, never exposed to air. Lumens must be kept in sterile, exits must be kept closed for all the times. Each time catheter hubs must be replaced with a new one. Thank you for watching my class.